Hi, I'm Dr. Stephen Bradley. I'm an anesthesiologist, and I'm the host of Ask an Anesthesiologist. That's the title of my YouTube channel. And through this site, I want to answer common questions about anesthesia, mostly centered around questions that patients are answering or patients are asking. In addition, I talk about my career as a physician in the military, and I will be talking about medical ethics as well. Today I want to talk about the big deal with COVID-19 and surgery. So if you remember back to the beginning of the year, back in March, April, when the COVID-19 virus was spiking across the country, a lot of decisions were made about how medical care would proceed. A lot of doctors' offices went to virtual visits, or for a while they weren't able to really see patients in person. So a lot of changes were made during that point in time. As an anesthesiologist, I work primarily in the inpatient setting, doing anesthesia, a little bit of work in the ICU, and some pain management stuff on the floor. So it eventually got around to affecting my practice. As the numbers grew this past spring, there was that common term of flattening the curve, and to that end, a lot of things happened, one of which was the cancellation of elective surgeries. So when it comes to surgical procedures, there's different categories. There's elective, there's urgent, and there's emergent. Elective just means it's a choice. You can kind of have this surgical procedure whenever you feel like it. This is like maybe having a mole removed, or having a breast augmentation, liposuction, cosmetic procedures. A lot of those are considered elective. There's no true time-sensitive nature to those procedures. You can then move on to the urgent category. When you have urgent surgeries, there is a time-sensitive component, so you're thinking about surgery for cancer, whereas the longer we let that cancer go, the more it's going to spread and the worse effect it's going to have on that patient's life. And then there is the true emergency procedures when you're in a car accident or you have a broken bone and that needs to be treated and fixed as quickly as possible. So for a lot of hospital systems, surgery is one of the big money makers for the hospital system. So canceling elective surgeries profoundly impacted hospitals' revenue streams. So it was interesting to note, in the beginning, everybody was concerned about where the country was heading. There was the institution of the mask mandates, and there was a lot of concern over the cancellation of these surgical procedures, and to the point that some people blamed physicians for canceling these cases and attributed some financial gain to that. Like the doctors were making more money because they weren't operating, which is absolutely inherently false. Because for a surgeon to make money, they need to operate. So to the contrary, physicians and surgeons were so concerned about the spread of coronavirus and the health and safety of their patients that they did not perform surgeries. So basically they did not make money during those times that they weren't doing elective surgeries. So business dried up across the country for a lot of practices, but it was a safe thing to do. The thing we were dealing with at the time was a lack of protective personal equipment, so PPE. We didn't truly know how to treat patients that were suffering from COVID-19. So we were behind the 8 ball. The curve was not flat. There were still cases spiking. We didn't really know what we were dealing with. So the safest thing to do was to cancel cases. And it wasn't that simple. It wasn't just a blanket cancellation. Different hospitals and surgical groups and hospital administration, in conjunction with the physicians that they work with, had to sit down and advise which cases are considered urgent, which are emergent, and which are elective. And your physician would have then advocated for you if their concern was this procedure needed to go sooner rather than later, as opposed to delaying this procedure. So things like, you could have a patient that needed a total knee replacement. Is this total knee replacement elective, urgent? Probably not emergent. But your surgeon will have that conversation. It's purely elective or it's urgent because it's affecting this patient's quality of life, and other things are going to go bad if they don't have this knee replacement done. So these were very difficult conversations. It's not a one-size-fits-all, and it's not just a blanket cancellation or continuation of surgical procedures. It's very, very complicated, complex topic. what is the consequence, or what would have been the consequences of continuing on with surgeries? So there's different types of surgery. Some are outpatient, where you'll come in, have your surgery, and go home that same day. Sometimes you need to stay overnight after having your surgical procedure. The problem with patients staying overnight, well, first of all, we're bringing more patients into the hospital. And we already, at that point, were canceling cases and canceling inpatient doctor's appointments to decrease the number of patients that are coming to this hospital and getting mixed in and exposed to patients that were positive for COVID-19. So that was the biggest deal. If we can decrease the number of people coming to the hospital, then we can then decrease the number of people exposed to COVID-19. When it comes down to patients who are going to perhaps stay the night, but we never know. A lot of times you have your surgery, you're supposed to go home, and you do, but every now and then there's complications or other things happen during surgery where it's safer for that patient to stay in the hospital. If this is an elective case, you're now bringing patients into the hospital where they can be exposed to COVID-19, and then they're spending the night. That's more exposure. And on top of that, remember, the big issue was there weren't enough hospital beds. And even if there are hospital beds, because that's not the true limit for any hospital. Any 1,000-bed hospital, for example, has 1,000 hospital beds, but those hospital beds are nothing without the nursing staff and the certified nursing assistants and the physicians to be able to staff those hospital beds. So it was a twofold problem. One, hospitals were running out of beds physically, but they were also strained to provide the staff to staff the bed that they did have. So you can see now that bringing in elective cases that potentially had to stay overnight would further decrease those hospital beds and block out other patients that had COVID-19 or other problems that needed those beds. So for the state of public health and to do the greatest good for the greatest number, the cancellation of elective surgeries was done nationwide, and a lot of times it came down from the state. So state mandated that elective procedures be discontinued. So we got through that first spike, we flattened that curve, things started to open up throughout the summer, surgeons were starting to work on that backlog of cases, and now in the fall and winter, we're starting to see the increase in number of cases again, to the point that once again, we are considering, in some places they are canceling elective surgeries, and some places where the prevalence of patients infected with SARS-CoV-2 or lower, surgeries are still continuing as normal. Flashback to March and April, we were so concerned about the outbreak of coronavirus that there was actually anesthesia departments where anesthesiologists, so we do spend a fair amount of time in residency working in intensive care units. That's pretty much part of our job description. We keep patients safe and comfortable during surgery, providing anesthesia, but we also are intensive care or ICU trained physicians, and then we do pain management. So a lot of departments were shifting back into that ICU management model. We were converting post-operative care units, so PACU, where patients go to recover from anesthesia. We had set ours up to be able to take ICU patients, and some places even in the operating room were prepared to have patients in the operating room because the beds were that short to provide patient care. The last and final reason, or not last and final reason, but another good reason that we were very hesitant to continue bringing patients in, we didn't have great testing back in the beginning where we didn't know who did or did not have coronavirus. And the risk that incurred is we bring somebody back, they've already brought the patient to the hospital where they may have not been exposed, or they may have exposed somebody else. Now you're exposing possibly a surgeon, the anesthesiologist, the nurse in the operating room. We're going to intubate the patient. For most surgeries, a lot of surgeries, you end up getting a breathing device, and the manipulation of the airway can aerosolize that virus. And then we're going to hook you up to a anesthesia breathing machine. So if you were infected, there's a chance that if we're not using the right filters, and we had to figure out which filters are the best ones to use to protect the machines, because they have these anesthesia machines that are, I don't know, probably $300,000 machines, and they help you breathe. If you seed that machine with coronavirus, well, now it's either ineffective, and if we know that it's been infected, then we have to take it offline, or worse, we don't know it's infected, and now patients that are going to come back behind us and get connected to that anesthesia machine, it could get infected with coronavirus. So those were the issues, some of the issues that we were dealing with back in March. We restarted surgeries. We had reliable testing. All of our organizing bodies, so the American College of Surgeons, the American Society of Anesthesiologists, and the Peri-Op Nursing, we all kind of got together to devise guidelines for how we manage patients going forward to provide surgery safely. I know at my hospital and a lot of other hospitals, you have to have a negative COVID test. Thankfully, we have adequate testing now. Remember, we didn't have that back in March, but now you can get tested. So you can get tested a couple of days before. We tell patients to stay home so they're not exposed to anybody with coronavirus, and then they can come in for their procedure. We still wear appropriate PPE with the N95 mask and eye protection because we are manipulating those airways, and there are, false negative tests. And that's kind of how we've been proceeding with surgery carefully. So the point of this video, if you're concerned about the thought process that went into cancellation of certain surgeries versus others, I just wanted to share a little bit of the background on that and how it came to those decisions. Again, these were not easy decisions to make. And oftentimes there's a group of physicians in a room that are talking and advocating why this patient needs to go and this one doesn't. So it was very, very difficult decision to make. We don't take that lightly because it does affect each and every one of our patients, and each and every one of our patients is affected in a different way. So hopefully that answers your questions. What other questions do you have about COVID-19 and anesthesia or surgery? Please feel free to drop those questions or comments below. If you like this video, give me a thumbs up. Subscribe to the channel. What do you want to know about anesthesiology and COVID-19? Again, I'm Stephen Bradley, your friendly neighborhood anesthesiologist. Thanks so much for watching, and tune in to the next video.